Well, here we go. So the first one is indeed about Eric. Very quickly, just to remind you, it's a German organization by law. It's a non-profit organization, but our executive office is in Barcelona, for whoever, if you want to come and visit. And as mentioned by Mr. Bombacci, we are the CLL working party of the Leukemia Net and the scientific working group for CLL at of the European Hematology Association. So I have to say that when we talk about CLL in Europe and hopefully also outside, Eric is a major player. The pointer doesn't, okay. So as I said, 1,057 members. Here are the countries with most members. These are the top 10. As you can see, already a 10th is not in Europe, is Israel. And then we have, as I said, members from Argentina, United States, Australia, and Taiwan, and so on. So we go to the topic of the talk today, but I want to do a step backward. Meaning that, of course, our attention, our interest is on the molecular testing, which really changed the way how we stratify the patient and we choose the right, we can choose the right treatment for each patient. But I just don't want to, as I always say also to the physician, I don't want people forget about the way how to manage the patient. So before we get to the treatment of a patient, we have a long phase most of the time where patients do not need treatment. And in general, patients with CLL very rarely need immediate treatment at diagnosis. So it might be only a few months, but there is always a wait and watch period in contrast to any other tumor. So of course, and for this reason, at the diagnosis, at the end, in the updated guidelines, the WCLA guidelines, the only thing that you need to know is the complete blood cell count and the immunophenotype to make the diagnosis, nothing else. So not even any imaging is required, and this is also like Professor Rai, Kanti Rai is saying, I mean, you don't need to do that, to see that, because when the patient needs treatment, the lymph nodes must be very large, and therefore there you can palpate them, or you can even palpate them in the abdomen. So you, in theory, you don't need any imaging for a patient to monitor a patient. Having said that, we all do, for tradition now, at diagnosis, we do a X-ray, chest radiograph, once in a lifetime, not every month, or only the first time, because typically CLL does not have lymph nodes in the chest, unless in very late advanced disease. And then we usually do also an ultrasound of the abdomen just to have a clear picture of what's going on in terms of lymph nodes. But definitely, and please, this is written in the guidelines since 10 years, not only in the updated one, we don't need definitely to do an aspirate, and we don't need to do definitely a CT scan. So this is something that sometimes patients ask, and sometimes they go to other doctors because he did the bone marrow because he's more careful, and therefore they move to other doctors because they do bone marrow biopsy at diagnosis, which is wrong. Then we have patient can or cannot, but sometimes can progress and need the treatment, and treatment is only applied when the disease is active or it's progressive. Only in clinical trials, now it's a research question to treat patient, asymptomatic patient, non-progressive patient. But this is definitely a very important research question, but the treatment applied to non-symptomatic patients should be used only in clinical trials. And here are indications for treatment. So the concept of active disease, which creates a lot of problems for the patients as well for the doctors. So I think that the best way is to inform the patient when they should be treated, so that the doctors don't get scared, because most of the time it's the doctor who gets scared, not the patient. So this is, hey, I can tell you, this is my work every day to reassure doctors, not to reassure the patient. The patient is always very reassured, but to reassure doctors. So these are the criteria, okay? And the most important, one of the most important is bone marrow failure, meaning that the patient is becoming anemic or thrombocytopenic. Anemic means below 10 grams per deciliter. It's not only that the hemoglobin is decreasing. That can happen. If you are 14, it becomes 13, it becomes 12. Fine, it's fine. No need for treatment if you go below 10. Platelets. There can be thrombocytopenia. In the old guidelines was the trigger for treatment was a value below 100,000. Then we recognized that probably doesn't matter. And in fact, in the new guideline, it says that even below 100,000, if it is stable or if it is 80,000, nobody is risking anything. It's not a risk. There is no risk of bleeding with 80,000 thrombocytes. So if that is the only thing that is happening in a patient, think twice before starting a treatment. And now it is written in the guidelines. Second thing, which is the second most important reason, is lymphadenopathy. The limit is 10 centimeters, which is completely different from any other lymphoma, where it is 5 centimeters limit. It is 10 centimeters. How many times I have to explain to doctors that they should not treat patients with 6 centimeters? And this we learned throughout the years, meaning that in the original guidelines, we always said that we had to treat patients with 5 centimeters. But already in 2008, we realized that 5 centimeters doesn't mean anything. Nobody's going to die because of a lymph node 5 centimeters large. And so we said, let's wait until 10, probably even 10. Sometimes I wait even to 11, 12, really depending on the patient. So just to understand that we have to be, again, very careful before starting a treatment, only based on the size. And then the other two things is splenomegaly. Usually you don't decide treatment based on centimeters, but on being symptomatic. So in particular, if it induces anemia or thrombocytopenia. And then there can be autoimmune anemia or autoimmune thrombocytopenia not responsive to corticosteroids. If there is only hemolytic anemia or autoimmune thrombocytopenia and it is responsive to steroids, then the patient should not be treated for the leukemia, but should be left again in wait and watch. Of course, most of the patients get stressed, and the doctors in particular, because in the guidelines it is also written that indication for treatment could be progressive lymphocytosis, which means lymphocyte doubling time, lymphocyte doubling within 6 months. Yes, that's a sign of progression. That's a sign that the disease is going somewhere. So sooner or later the patient will need the treatment, but it's not that the moment when the patient needs a treatment. And this should be very clear. We wrote some years ago with Michael Alec here in 2014 that is rarely, the lymphocyte doubling time, it should be really rarely the reason to start a treatment. I never started a single patient treatment in a single patient because of lymphocyte doubling time. It means that the disease is moving, but if it doesn't have, he or she doesn't have lymph nodes above 10 centimeters, it's not anemic or thrombocytopenic, I don't start any treatment. And I show you a case because luckily we have now new drugs, new treatment for patients that taught us a lot about how to manage the patient, not how to treat the patient, but how to manage the patient. This is a patient who relapsed after the first line treatment, was not my patient. So he started 10,000, 14, 37 in a number of months, 66, 174, he tripled even. So here the patient got scared, the doctors even more, and they said, let's start the treatment because you fit the criteria. There is a lymphocyte doubling time that is too short. And just because he wanted to be innovative and modern, he gave ibrutinib, of course. And guess what happened? After 1 week, we had 337,000 lymphocytes. And the patient came to me. And I said, don't worry, if you were dead before, if you were dying before, now you are dead because of this. So the problem is if you were scared of 174,000, I mean, now I don't know what you could do. And that's what we learned. So I told him, you didn't need a treatment here, you don't need a treatment here, you just stop ibrutinib, you go back to your regular normal life. And so what we learned using these new drugs, that indeed the only relevant things are the invasion of the bone marrow, anemia and thrombocytopenia, and the lymphadenopathies. And in fact, the new drugs are very potent in reducing the lymph nodes and in emptying the bone marrow. And they increase the lymphocyte. But it's not a side effect, it's just a phenomenon, okay? So we learn even more that the number of lymphocytes in the blood is not an issue. And nowadays I have to say that there is kind of a game among the CLL experts who had the patient with the highest number of lymphocytes. And we are there, meaning that I was the most humble among the experts, so I mentioned 800,000 lymphocytes. And then Professor Halleck said I had 1 million. And then the British Empire came back striking with Professor Hillman, 1,200,000. So, but beside the jokes, is really to make you understand that nothing happens because of the lymphocytes. These are small, they go around, nothing happens, it doesn't clog this patient. Of course, if you have 1 million lymphocytes, there must be something else. So probably you have large lymph nodes or you are anemic or thrombocytopenic. But you are not treating the patient because of the number. You treat because of the lymphadenopathy or because of the anemia. So another criteria, and then I close and go to the focus of the talk. But I think it's important because now we always think about spending money doing complex testing and so on, while instead we could save lives and years of life, of good quality of life, just with nothing, doing nothing. Another indication, which is also something the patients tend to complain, doctors, they get stressed. I usually don't pay too much attention. I always say, I'm sorry you are tired, but I don't know if it is the leukemia. It can be because your wife is snoring at night. It might because you have problems at work. Whatever, I cannot treat a patient, give chemotherapy in the past because he is tired. I mean, he will be even more tired after the chemotherapy. So this is exactly the point. So we have an intentional weight loss. As I always say, if you lose more than 10% of your weight, regardless having CLL or not, I would go for a colonoscopy or a mammography if you are a woman, because I never saw, it doesn't exist that a patient with CLL loses 10% of the weight as the only symptom. If that happens, it's usually a solid cancer. Okay.
Why mammography? Why mammography?
Or because of a breast cancer.
Also thinking.
Just
Yeah.
prevention.
Yeah. No, it's a cancer. The first thing that we teach to the students, if a patient loses 10% of the weight, you must think about the cancer. Then, if you don't find it, we try to look for something else. But definitely not, it's not the first symptom of a CLL. Nobody will ever come to you with 10% weight loss and you suddenly find out that he or she has a CLL. It can happen when the disease is progressing, so you have large lymph nodes, anemia, and so on, so you might also start losing weight. Significant fatigue, as I said, everyone can be tired. Who is not tired here? Everybody. Fever, usually it's fever at night, low-grade fever, night sweats, again, especially in Italy. I don't know if there is someone from, or colleague from Greece. Most of my patients come and they sweat in summer. I said, fine, I'm doing the same, so it's not really an issue. So meaning that we have to be very careful. Again, besides jokes, it's very difficult to take the decision to treat a patient based on these symptoms, which are not symptoms, are referred information, and you never know, they can be for many other reasons. And typically, when a patient has any of these, the disease is showing progressing. So lymph nodes are large, patient is becoming anemic, so there must be something else that is really telling you that the disease is progressing. If all the rest is fine, lymph nodes are 2 or 3 centimeters, and the patient comes in and is tired or is sweating at night, and tell him to buy the air conditioning. It's not definitely, I'm not going to give you treatment. And again, I show you here, again, the new drugs helped us to learn about this. Ibrutinib, which is again a wonderful drug, I can mention anyone else and any other drug, venetoclax, idelalisib. 50%, 30% of the patients, they claim they are more tired after they start the therapy. So if that is the reason why I start the therapy because you are tired, would I give you a drug that it can even make you more tired? So it doesn't make sense. I give you a drug that reduces the lymph nodes because the problem was large lymph nodes, or a drug who emptied the bone marrow because the problem was the CLL in the bone marrow giving anemia. All the rest is very questionable. Having said that, we go to what we have to do as doctors, but as patient you have to pretend when the disease needs a treatment. Okay, so most of the things are basic things, complete blood cell count. Now you do a bone marrow aspirate. It's desirable, it's not really mandatory. You could even start, especially in the elderly, you might even start treatment without a bone marrow biopsy, but typically, if a patient can stand it, I would do it. Chest radiograph and abdomen echography, and so on. But the most important thing which appear now in the guidelines is indeed the molecular testing. So we have to do something else now, at the moment of progression, at the moment of need of treatment. One is the FISH, which was there around already since at least 10 years. I think that FISH is done quite frequently. We did a couple of studies around. I think that more or less 70% of patients in Europe, for example, receive FISH testing. But the most important thing that now it is mandatory to test the patient also for p53 mutation. Why is that? So we know that on chromosome 17 there is the gene p53 is located, and we know since at least 20 years that the presence of a deletion of the chromosome 17 is associated with a poor survival of patients with chronic lymphocytic leukemia. And we learned more recently that only a single mutation on the gene, on the p53 gene, so even if the chromosome is still there, the gene is there, but there is a mutation in the gene, then the patient has a bad outcome, similar, here in red, similar or identical, superimposable to the one of the patient with the deletion of the entire chromosome. So really suggesting that the p53 gene is the key. And for many years you also heard, and the doctors also did, tested patient at diagnosis, because they said, but this is prognostic, so if you have the mutation, I can tell you that you will have a short life. This is not true, because p53 deleted or mutated is a predictive marker. So the fact that the patient with such aberration have a short survival depends on the fact that when they needed past. When they needed treatment, we only had chemotherapy, and having a mutation in p53 or a deletion of the p53 gene associated with resistance to chemotherapy. So it's only predictive of the fact that the patient will not respond to chemotherapy. But you can start at the beginning, and if you start disease even with such mutation and you don't need a treatment, you can have a very long life. Questions later?
Yeah. Later?
Later.
Okay.
We go quickly. So now with the new drugs, the survival is definitely better. Here it is PFS, it's not even overall survival. It's PFS already more than 2 or 3 years. So the problem why we are so keen about this is because, as I said, most of the patients receive testing for FISH, but they do not receive testing for a p53 mutation. And many patients have only the deletion, only the mutation. So if you don't perform that test, you will receive chemotherapy, though you shouldn't. And it is so important that the ERIC created a P53 network with a number of laboratories around the world now that can help other laboratories to set up the technique. And they are certifying these laboratories so that everyone is sure they will get the right and the appropriate diagnosis at the time of needle treatment. The other important thing that came out in these guidelines is that the immunoglobulin gene status also is mandatory before starting a treatment. Again, it was considered to be a prognostic marker, so we were testing in the past at diagnosis. If you were mutated in the immunoglobulin genes, we could tell you, don't worry, your life will be long. If they were unmutated, we would have said perhaps it will be a little bit shorter. Again, it is not true. That is again because the immunoglobulin gene status is predictive of a response or a lack of response or a poor response to immunochemotherapy. So it's not a prognostic marker, so should not be tested at diagnosis, but is a predictive factor, so should be tested before starting treatment. And here I show you that the patient with mutated immunoglobulin genes are the ones that can reach a plateau with immunochemotherapy, so they could be even considered to be cured. While instead those without the mutation, they tend to relapse quite soon and progress earlier. I have just to remind you that unfortunately patients with the mutated immunoglobulin genes who are young enough to be treated with fludarabine, cyclophosphamide and rituximab, which is the most effective treatment, are very few, only probably 10-12% in each center. So, but those patients should be still treated with chemotherapy when they need treatment. All the others should be treated with the novel inhibitors. And this is again why Eric set up also a network for immunoglobulin gene analysis, the same concept. We have laboratories that are helping other laboratories to set up the test. They certify the quality of the test so that everyone all over the world can have this test available, and in particular is certified. So this, just to conclude, this is a scheme that every patient should pretend from the doctor, should pretend to have a wait and watch period. It's not possible, it's very unlikely that the patient has to be treated immediately. After that, if the patient is progressing, lymph nodes, bone marrow invasion, should be screened for P53 status, both deletion and mutation, and also nowadays for the immunoglobulin gene status. So in conclusion, no molecular testing at diagnosis. This is a waste of money. It creates only worries in the patients, but doesn't really change a lot. No bone marrow aspirate, no CT scan, but yes, molecular testing before any line of treatment. And then please keep in mind about the reason to start treatment. Pretend to be treated when you need to be treated. Thank you very much.